Welcome to the second podcast episode of Radiology AI. My name is Dania Daye, and I'm the Associate Editor for Social Media for Radiology AI. Today, we will be discussing the claim checklist that was recently published in the journal. This is the checklist for artificial intelligence in medical imaging. Today, we are very lucky to have with us Dr. Linda Moy, who is Professor of Radiology at NYU, and Dr. John Mongan, who is Vice Chair of Informatics and Abdominal Radiologist at UCSF, who will be discussing this topic and are the authors of an article that was published in Radiology AI on this topic. I will turn it over to my co-host, Dr. Paul Yee, to start the discussion. Paul?
Thanks, Dania, and thank you to Dr. Moy and Dr. Mongan for joining us. I'm really excited to have you here. So we heard a little bit about your background, Dr. Moy and Dr. Mongan from Dania, but could you tell us and our listeners a little bit about how you got involved with AI research and informatics and pretty much all of the above?
Sure. So I'm Linda Moy, and I'll start first. So I am a breast imager, and I assume most of us know that multiple randomized clinical trials have shown that mammography does decrease mortality from breast cancer, but in the press you can see it's an imperfect tool. We miss breast cancers, we recall patients for a lot of additional imaging. And CAD, which is the computer-aided detection, was developed to address these limitations, and although we've used it many years clinically, I'd say most breast imagers would say it's not helpful because there are too many false positives. So when these deep learning tools started to pop up, I thought this is really a great opportunity to address this. It became a big research interest of mine. And I think about 5 years ago, I started collaborating with computer vision experts and data scientists at the NYU Center for Data Science. And then we were fortunate enough to obtain NIH funding, and now we've developed our own model, trying to improve the diagnostic accuracy of mammography, ultrasound, breast MR, and other breast imaging tools.
Yeah, that's great. And Dr. Mongan?
So I've had a long-standing interest in computers and computer science and application of computers to medicine. My PhD is in bioinformatics, and throughout my career as a radiologist, both as a trainee and then when I joined the faculty at UCSF, I'd had a focus on informatics, both clinically and research. And in I think it was 2016, one of my colleagues, Alvin Rajkumar, who was actually a hospitalist, not a radiologist, but came to me and said, I've been to some of these conferences on deep learning, and this is going to be big, and we need to get on this, and you need to look into this. And so I started looking into it with him, and I said, you're right. And so we started, from the concept of you should walk before you run, we started with a really simple application. And the first paper we published was on detecting the orientation of a chest radiograph. I was just kind of blown away by the results that even we as novices at that time in the field were able to achieve, getting nearly 100% accuracy on this admittedly fairly simple problem, but still a non-trivial problem. And then, our work and my involvement just kind of grew from there. We moved to kind of some more clinically relevant research topics, did some work on detecting pneumothorax and radiographs that we licensed to a modality vendor to incorporate into one of their scanners. And I became involved with the RSNA Machine Learning Committee and helping to run some of the machine learning competitions, and then involved with publications and journals and reviewing articles, and involved with Radiology AI as well.
Yeah, Dr. Mongan, I remember that first paper, the frontal versus lateral chest radiograph paper, is one of the first deep learning papers I got acquainted with. And Dr. Moy, I actually had the great pleasure of hearing you give a talk at Hopkins a few months ago for Grand Rounds. And something that I think is really exciting is that the common point here is that we're all radiologists, and we all recognize that this technology of AI and deep learning really has great potential to change paradigms in our field and improve patient care. So with that in mind, can you tell us a little bit about how the claim checklist came to be? What's the origin story?
So I think for me, and I think Dr. Moy and I kind of came to this from maybe slightly different starting points and converged on working on this together. But for me, I think this grew out of experience reviewing articles, particularly reviewing articles for Radiology AI, and the commonalities that I noticed in the reviews that I was writing, that there were a lot of issues that were coming up over and over and over again, and that really many of them centered on on reproducibility, on, looking at a paper and saying, would I be able to sit down with this paper and do the same thing that the people writing this paper did? Or would I be having to guess at what it was that they did? And, kind of both that frustration at writing the same things over and over again and wanting to try to move the field forward to a place where we're all writing better papers for each other to read and able to benefit from that higher quality of papers. And so I discussed this with Dr. Khan, I think at an RSNA meeting, and he was receptive to the idea that this might be something that would be worthwhile and important. And I had some time on the plane flight home from RSNA and wrote out kind of a draft or an outline of what some important points I thought were commonly missed or common mistakes in these publications. And that was kind of where my start in this came from.
Well, I want to emphasize that Chuck and John are really the true architects, of this. I came to them because I really needed a checklist for us to know how to write about our research and also how to review it. So I serve as the senior deputy editor for the journal Radiology. And I'd say about 2 or 3 years ago, we started to get a lot of submissions of AI papers. And now it actually makes about 25% of all those submissions. And, inherently, these papers on deep learning are different from the typical papers we get where we're focused on diagnostic accuracy. Is a new MR or CT sequence or a new technology, as good? Does it add more information? So right away, the language for these AI papers was different, and we needed tools to better understand how the data was acquired, how the data was pre-processed, how to evaluate it, to understand the model and to evaluate its performance. For me, from a journal, it was important to have reviewers and editors also become much more consistent with how we're evaluating the data. But the big golden days, what John said, we want to have reproducibility. So if I read a paper and it's really cool results, I want to see, hey, can I test it using my data set?
Yeah. So, thank you for telling us a little bit about how this came about. And I think the motivation that I'm hearing from both of you is that, motivation is really to increase the quality and make sure that we increase the quality of science and make sure that we hold our AI research to the highest standards. So with that in mind, for our listeners who might not be acquainted with CLAIM, especially because it's so new, can you walk us through a high-level overview, kind of a summary for someone who may not have even heard of it up until this point?
Sure. So I think, as I see it, the goals that we're trying to achieve through this is really to improve the quality of manuscripts that are written on artificial intelligence in medical imaging. And so the two kind of central themes that I think everything in this really stems from is that the reader of a paper should be able to exactly reconstruct what the methods were that the investigators who wrote that paper applied. And that the reader of a paper should be able to evaluate the quality and the generalizability of the results in that paper. And I think all the details in the checklist really stem from those two themes. And so the checklist itself is organized in the same structure that a manuscript would be organized. And for each section in the manuscript, we have points that outline the things that generally should be present in that portion of the manuscript and what some quality indicators are of what types of things you see in investigations that are of higher quality and higher significance, and what types of things you see in investigations that are of lower significance. And I think a lot of this focuses again on this idea of reproducibility or the ability to reconstruct the investigation. And so when you look at the checklist, you'll see that of the 42 or so points that we have in it, 28 of them have to do with the methods section. That's the part that we often see deficiencies in that really make it difficult both for someone to reproduce and build on the work that was done and to fully evaluate what was done to be able to understand whether that was appropriate approach or not.
John said that so eloquently. The only thing I can add was, for me, we wanted to have sort of a checklist to avoid some of the problems that we saw with CAD for mammography. The initial studies were all very promising. They all looked to be really well done, but as we started using in clinical practice, we ran into issues of the data wasn't reproducible. We couldn't generalize it was done in one setting. I'll make it up a high-risk patient or a different ethnicity. And all of these issues, I don't think we really realized how valuable it was until we started looking at this big data. And this is when some of these standards of methods of data, what the ground truth is, how you're training the data, all that became very important to understanding whether these results would be reproducible.
Thank you both for the summary there. And thinking about, Dr. Moy, you mentioned that we want to avoid what might have happened with CAD in the past. And so we've had these more traditional diagnostic study checklists, like the STAR checklist. And, I've noticed that on the claim checklist, there's many items that are pretty standard, while others are more AI-centric, like descriptions of the specific algorithm architectures from, like said Dr. Mongan, to reproduce the studies and software libraries and versions used. So in light of that, are there any items on the claim checklist that you think bear some further explanation or emphasis for those doing AI research?
So I think that one important thing for listeners to be aware of is that the article that we wrote that accompanies the checklist does go point by point through the checklist and provide explanation and background and flesh out each one of the points in the checklist. And I think that it's important to not try to use the checklist in isolation, but use the checklist in conjunction with the article that really defines what those points mean. And then once you remember and internalize those, you can use the checklist by itself to remind yourself of those points, because each one of these points really has more meat behind it than the one phrase that's in the short sort of 2-page version of the checklist can convey. I think there are, as you pointed out, because this is focusing on artificial intelligence rather than some of the more general just evaluating diagnostic tests or evaluating classification kinds of things, there are some specific points that that are fleshed out in this article, but that maybe merit mentioning. And without getting too far off in the technical weeds on this, I think some of the things that can be a little unfamiliar to reviewers reading these articles or to investigators who are new to this field. One of them that's really important in this is partitioning of data. So I think that in a lot of areas of research in radiology, you invest a whole lot of work into collecting your big data set, and then that data set is the thing that you analyze all together in one piece. But for these artificial intelligence investigations, it's really important that you divide the data set up that you collect. And generally that's divided into 3 pieces: a training set that you train your algorithm on, that the machine learning actually does its learning on, a validation set that you use to monitor the progress of your training. And if you try multiple different approaches to your training, you use to choose which one of those approaches you think is most effective. And then a third partition, a test set, that you really kind of keep up on the shelf and separate until the very end, when you've selected the training approach and the algorithm, the trained algorithm that you think is the best, that you then apply only at the very end to try to see what the performance would be like generalizing to a set of data that the machine learning process had not yet been exposed to. And so I think that partitioning is important. And what's another sort of, I feel like, more subtle point that took me a couple years to get to is the level at which you do that partitioning is really important, because the individual data points in your data set are oftentimes not fully independent from each other. So for instance, if you have an algorithm that acts on single slices, single images from a CT scan, you can think about hierarchically that data. Each one of those images comes together in a set that forms a study, and then you might have multiple studies that all come from the same patient. And so if you were to take your algorithm that's going to only act on single images, and you just, without consideration to where they come from, partition your data set up by the image, then you may end up with images from the same study that are both in your training set and in your test set. And your algorithm is going to look like it performs much, much better than it actually does on that test set because of those incredible similarities in those images that are coming from the same study. So it's really important that in that partitioning, you look at the level at which those partitions are disjoint. And in general, you want to make sure that you don't have any patients that exist in multiple different partitions. Each patient should exist in only one partition. One other thing that I see that, I think commonly happens in these things is sort of an imbalance in the level of description that's given to hardware and to software and the importance on it. And I'll oftentimes see manuscripts that spend a lot of time describing the hardware that they're running things on, how much memory the computer has, how much disk space it has, when in fact, that doesn't generally really matter. You generally get pretty much the same results, regardless of what hardware you have on it. You may get it a little bit more quickly or a little bit more slowly, but the hardware doesn't matter. Conversely, oftentimes people don't really describe in much detail the software that they're using, the specific frameworks, the specific versions, the settings, the option flags that they're using, but that has a huge impact on what the results are that you get. And if someone's going to reproduce your results or reproduce your methods, they really need to know exactly what software you used, exactly what versions they were, and all the different settings that were employed along with that software.
Well, you can just see how much of an expert John is in this field. So I think I'm just going to add a few comments, but focusing maybe more on a topic that we've touched briefly on, which is we really want to have transparency of these AI papers, and not only with the methods, but with the results. I'm going to spend a few minutes and maybe talking about the model performance that I think is worthwhile highlighting. If you read a paper, most of the time, the authors will just say, well, we have an AUC of 0.9 or so forth, and that turns into everyday English as, wow, this is really good. And if it's being performed with a certain vendor, the underlying idea is, well, this is something that should work in your practice. And I think we are trying to make that more nuanced. When we talk about the model performance, we go back and sort of say, well, how are you reporting this? What is the true benchmark for the performance of the AI model? What is the true reference standard? Is it pathology? Is it a group of really expert radiologists who you're comparing it to? Is AUC the only metric that matters? For me, I think as we're starting to see some of these software being in clinical practice, it's this concept of explainable AI, saying, okay, if this paper is telling me that this model can tell me whether there is going to be COVID, or no evidence of COVID on the CT. I want to understand this model. Particularly the idea of a failure analysis, where there are instances where the model is completely wrong, and can we understand why it made this mistake? Or just to help us better understand the algorithm. I think as we all get more comfortable and these tools really become integrated into clinical practice, that this model performance is really going to be a critical step of the papers for us as authors and as reviewers.
Yeah, I think that's really interesting. And one thing that I'm hearing from both of you is that, there's really this kind of intersection of clinical components of a study that make something high quality, that make them complete, that make them reproducible, but also technical as well. We can get really into the weeds with the details and claim probably for hours. But, just to tie this discussion, are there any take-home points that you'd recommend to our readers, either researchers submitting papers, radiology AI and radiology, or reviewers, or just readers of manuscripts published in the journal?
So I think for me, returning a little bit to something we discussed earlier, is that all of these points are specific examples of the underlying themes of reproducibility and the ability to evaluate the quality of work. And I think that this idea that you can look at the manuscript, that you can read the manuscript and understand everything that they did is really a key component. It's, the distinguishing hallmark of science is that someone else can go and do what you did and evaluate it for themselves, make sure that it's something that's actually reproducible, and then build on it themselves. And a scientific paper, a manuscript, is really a communication from the people who did the work to other readers so that they can evaluate it so that they can build on it themselves. And if we don't have these components in our manuscripts, if we don't have enough detail that someone can reproduce our methods, that someone can evaluate the quality of our results, then we're not really doing science. We're really all just playing with our computers and telling each other stories about it. So I think that the take-home points for me would be that when you're writing a paper, when you're reviewing a paper, consider the paper and ask yourself, is all the information here for someone else without sending me emails, without talking to me, to be able to completely reproduce every step that I took and to fully evaluate the quality and the generalizability of the results that I achieved? And so this checklist is really giving some specific examples of things where people oftentimes fall down on that. But it's really these overall themes that you should be looking for. And there may be other points that are important that aren't covered by this checklist that are essential for achieving those goals. But it's really those goals that I think that both authors and reviewers should be holding in mind.
I don't have much to add. I would say that we should just think of the take-home points. A claim is providing a framework for us to see applications of AI to medical imaging. An important point is that we as researchers, authors, and reviewers are just getting comfortable with this material. There's going to be an explosive growth in this technology, not just with diagnostic accuracy, but how you acquire images, how you really are using AI throughout the whole patient care continuum. So I'm hoping that as our AI research continues to mature, we can use this claim list and maybe even apply it to things that right now is just focused on a model and its performance.
Yeah, absolutely. And I think, one other sort of more specific point that I might add as a take home is, I mentioned that more than half of this has to do with methods, and a lot of the points on quality speak to issues in study design. So I think there's a tendency for these manuscript checklists to be something that people don't even look at until after they've written their draft of their manuscript and are ready to submit. But a lot of these issues that are highlighted in this checklist and the methods part of this are things that are ways that you can really improve the quality of your investigation, improve the quality of your work, that are much easier to address before you do it during your study design point than when you're polishing your paper for submission. So I would suggest to people, check out claim early. Look at it when you're designing your approach, when you're designing your study, not just at the very end of the line, because I think that there are some things there that are much easier to incorporate up front than at the end of the day.
Yeah, absolutely. Thank you both for those valuable take-home points. I think the claim is certainly going to be an important part as we enter this brave new world, if you will, about AI and radiology. So just to close our time, we're getting to the end of our episode here. Something that we ask all of our guests is, what are you personally most excited about for the next decade, either in radiology AI, informatics, or anything that you might see coming on the horizon?
I have to say, I'm really excited about the potential of AI to really energize our field. It's a disruptive force, which people would think of it as negative, but I think it's very positive. So for me, when I do a lot of oncological imaging, I think something that I'm most excited about is the idea of incorporating imaging, a lot of the patient's clinical and pathological information, sort of getting the big data to help us with precision medicine. I think patients want that, figure out which tests they want to get when they're being screened, when they're being diagnosed, if they have cancer, what is the treatment they should get, all this, how much risk they'll have of having recurrence. All this is critical information that I think we can see from being in this COVID environment, that patients want to virtual chat. They want to know all of these questions that we just can't convey when we're just dictating a MRI report. I think the other big excitement for me is I'm hoping that AI will make imaging tests available to more patients around the world. I think, again, in this pandemic, we can see the resources that wealthy countries have compared to others as we are all globally trying to treat patients with this pandemic.
Yeah, I completely agree with Dr. Moy. I mean, we're all physicians here, and so I think really the exciting thing that I'm looking forward to in the coming years is the translational work of really bringing this artificial intelligence to the patients, bringing to the point where it has impact on patient care. I think that we've had a lot of exciting work in these last few years around artificial intelligence in radiology and in medical imaging, but really most of it has been kind of proof of concept level, or at least large scale lab work, not so much actually having direct impact on patients. And I think that early on, there was a lot of discussion about artificial intelligence replacing radiologists. And if you're going to replace radiologists, then in a sense, that makes the translational work easier because your interfaces are just, an interface to the scanner and then an interface to the EHR to spit out reports. I think it's become increasingly apparent that replacement of radiologists isn't going to happen anytime in the foreseeable future. And really, this is going to come to the point of impacting care and helping patients by working in concert with radiologists. But that sets up its own challenging problem then of how do you integrate these artificial intelligence technologies into a radiologist workflow? How do you effectively get sort of man and machine to work together to provide improved care? And I think that there's a lot of important work that needs to be done around standardizing interfaces that I think IHE is taking some great initial steps on. And I think that's really what I'm excited for, is seeing these things move out of the lab, move into the reading room, move to the point of really improving the way that we can deliver care for our patients.
All right. Well, I'm excited. So thank you so much, Dr. Mongan, Dr. Moy, for joining us on the podcast episode. And I'll hand it back to Dania.
Thank you all. Thank you, Paul, Dr. Moy, and Dr. Mongan for a really great discussion today and for sharing with us your insights about the checklist for artificial intelligence in medical imaging, or CLAIM. I think, as Dr. Mongan said, a major take-home from today's episode is that everyone should check out CLAIM early as they're doing studies in AI and medical imaging. To our listeners, thank you for tuning in to our second podcast episode. Don't forget to rate, review, and subscribe to our Radiology AI podcast series on any of iTunes, Google Podcasts, or Spotify. Please stay tuned for our next episode.